Whoa. All right. Dani Williamson here, Integrative Family Medicine. And this is Dr. Bill Noah of Sleep Centers of Middle Tennessee. It's Wednesday night's church service tonight, apparently. You know, it's not Sunday, so I'm sure I'm surprising and confusing every single one of you. But tonight, we are talking about sleep apnea. We're talking about snoring is the loud killer. We're talking about heart disease, women's health, menopause, all the things, anything that's going to increase your risk of dying from sleep apnea, right? And so I've got the smartest man that I have ever met when it comes to sleep medicine. Dr. Noah he graduated from UT Medical School, and he's got a list a mile long we're not going to get into because we definitely want to get into all of this information. But he is board certified in pulmonary medicine, sleep medicine, internal medicine. He owns and founded Sleep Centers of Middle Tennessee. And I'm thrilled to death. I've waited 3 years to get this man here to talk to me. 3 years. I met him a long time ago. He's taught me so much about sleep apnea and, you know, the risks. So we're going to talk about it tonight. We're going to talk about the loud killer and what you've got, what's up your sleeve and what's been going on. Give us a few statistics right now while people are getting logged on. Guys, I want you to tell us where you're from and put your questions up here, because if we don't get your questions tonight answered, we will get them answered, because this will go to Sleep Center's Facebook page as well. So give us some statistics while people are logging on.
All right. Well, we have a pandemic going on in America right now.
Yeah, we do.
We do. And there are 34 million Americans that have been infected with COVID-19. There are 600,000 deaths as of earlier this week. That's a 10% of the population having COVID, 11%. And that's a death rate about 1.7, 1.8. Okay, so that's a pandemic. And, you know, how many times have you heard the discussion of vaccines or masks on TV or what you're looking at? Well, let me tell you about another pandemic that no one knows about, because there's no pharmaceutical company behind it, you know, making vaccines or making medications, you know, for whatever.
Right.
This is a disease we now call sleep airflow obstruction, but obstructive sleep apnea is the classic name. And this disease, not 11% of the population, but 37% of adults have this process. Of that, the death rate,
37% of adults
in the U.S. have obstructive sleep apnea.
37%.
Yeah.
Somebody type that in the notes, please, for us.
Almost 50% snore. So if you snore, there's an 80 to 90% chance you have it.
If you snore, there's an 80 to 90% chance you have it.
Well, most recent data suggests as much as 90. But the death rate for sleep apnea, untreated, is 40% over 15 years, not 1.7. But you don't hear about it. People don't know. In fact, more than 80% of those who have sleep apnea have not been diagnosed. More than 90% are not on treatment. 86% of diabetics have sleep apnea, and yet less than 5% are on treatment. And yet the CPAP, the most common treatment, would actually lower their blood sugars, improve their insulin resistance, help them lose weight. Heart disease, between 60 and 82% of heart patients have sleep apnea. Less than 5% ever get tested. We're talking even home testing or something simple. Hypertensive patients, back in 2003, the Institute for Prevention of Hypertension recommended that all hypertensive patients, especially those who snore, get tested for sleep apnea.
Yes.
That had happened. In 2008, the International Task Force on Treating Diabetes recommended that all type 2 diabetics be screened for sleep apnea, because 86% of them have it, and you can drop their hemoglobin A1C by a whole point with CPAP. 2 weeks of CPAP will improve insulin resistance in randomized trials. Yet they recommended this in 2008, and that's not happening. Over and over again, American Heart Association has recommended screening heart patients for sleep apnea. Well, in 2019, they were so big on it, they actually put a protocol out in the American Heart Journal, but no one's following it.
No, my dad just had a heart attack last month and out of town in Charleston. They never asked him about sleep or sleep apnea.
Yeah, of course not.
A friend of mine right now is on the phone this afternoon from my publishing company, just diagnosed with high blood pressure and all. I asked him, "Do you snore?" He said, "Yes, I do."
That's because you're enlightened.
He's never been asked by his cardiologist, though. You know, okay, keep talking.
So what's the most common time for a heart attack? Does anyone know what time of day the most common? Actually, it's like 5 to 1. that heart attacks happen at this time.
I thought it was like in the morning.
It is.
9
It's
to
6
10 or
a.m.
6. Oh, 6 a.m. Okay.
So what are
Before
you
you go to
doing?
work.
What are you doing? No, you're in REM sleep,
Yes, you
about
are.
to wake up. You're in dreaming
6
sleep.
a.m. is the number one
Yeah,
time.
absolutely. In fact, if you have a heart attack at 6 a.m., your mortality is much higher than if you have it later in the day, because you're having it coming in your sleep, because you're having these respiratory events. You're getting ischemic. You're in REM sleep, where it's actually worse because you wake up out of REM sleep in the morning. You remember the dream you're in. It's called dreaming sleep.
Deep sleep.
Yeah.
Yes.
And so your heart's, why is your heart stressed? Why are you having a heart attack when you're supposed to be, relaxing in a sleep?
Yeah. Why?
Well, it's because you're having obstructive sleep apnea. And I mean, it's just
he
the way it
talks
is.
like I do. It's because of her.
No, I mean, it's just, it's like, can you not get this connected here? I mean, what else is going on at 6 a.m., and that's the average, it could be between 4 and 8 in the morning is really when it is. And that's the most common time for the sudden death. A lot of people have family members who died in their sleep years ago. You say, oh, he
Yes.
died in his sleep.
Yep.
Sounds great. It is. It's a good place to die, but who wants to die?
It is a great place to
Yeah,
die.
and,
I would rather die right there.
Yeah, but I mean, why are you dying in your sleep? It's because you're having these respiratory events and you're having a cardiac arrhythmia. You're having sudden death from it. I mean, if this wasn't so serious, it'd be fun.
Did you tell me this statistic that 50% of all, no, wait, hang on a second. The first and last sign of cardiovascular disease for 50% of all patients is sudden cardiac death? Did I make that up, or did you say that one day?
No, no, I've never heard that.
Okay, well, maybe I made it up. I've told lots of people this through the years.
It sounds great, though.
Oh, it's real good. That's your first and last
guarantee
sign.
you're more accurate than news on TV. I guarantee you. At least you were trying to be truthful. That's right.
I tell patients I
That's
told
right.
somebody that today. Okay, all right. Well, anyway, but sudden cardiac death is bad news. So, yes.
Yeah, it's actually the statistic I always remember is that if you have an out of the hospital arrest,
Yes.
all right, 1/3 basically, never make it to the hospital alive. 1/3 make it, but end up not surviving the hospitalization. So you really have 1 out of 3 chances. Man. Is what that may be different now. They've got different technologies. But that was 10 years ago. That was it.
Well, let's talk about the loud killer then, and then let's get into, the majority of my patients are menopausal, perimenopausal, postmenopausal women.
Yeah.
I know that cardiovascular disease is the number one killer still for men and women,
Yeah.
but for sure the risk goes up postmenopausal. And
tremendously. I mean,
Yes.
it's the biggest change in developing sleep apnea. Sleep apnea worsens with weight and it worsens with age. In fact, I'm actually presenting later this year to my academy that we need to change to a staging process because it's not a static thing. Sleep apnea continues to worsen as you age. Your airway continues to get smaller during sleep. The biggest change is women at menopause. The hormones are, somewhat protective. And so the most common patient I see is no longer, this is crazy, it's no longer a man, even though sleep apnea is more common in men, certainly at younger ages. The most common patient we see is a woman in her early 50s, and she comes in because she's snoring now. She never snored before. She's irritated about it. She gained weight. She didn't like that.
yes,
And she may even start to have a little high blood pressure. And so she thinks, menopause did that. No, it's the fact the menopause, the hormones, now you have more airway collapse at night because the hormones are protective. And because the airway collapse, partial collapse, the snoring is causing the high blood pressure. The snoring is causing fragmented sleep, which worsens high blood pressure more. The snoring is actually causing elevated cortisol at night,
Yes.
causing elevated insulin levels because your blood sugar goes up and therefore you have to have insulin to respond. So that's how sleep apnea causes type 2 diabetes is that, when you have these flight or fight reactions, in other words, you're releasing adrenaline-like substance, sleep norepinephrine
Yes.
release, we call it. And as you're releasing that, at the time you're supposed to have a peaceful state, now you're releasing adrenaline. You're having a fight or flight reaction. Well, that's triggering blood sugar to go up because in response to fight or flight, that's an example of a fight or flight reaction. You just saw one, except she wasn't asleep. Just think about that going on hundreds of times at night while you're asleep.
Oh
so think
my
about
gosh.
that. So
I
you're
never
doing that.
thought of that.
So you're raising
That's
you're raising blood sugar, releasing glycogen into blood sugar to be ready to fight or flight.
Yes.
So your sugar goes up, all right, but there's nowhere to go. There's no one to fight. You're asleep. You're only fighting your airway. So because you're snoring. So then what happens? That gets converted to fat.
Yes.
So and then your insulin has to go up to get that back in the cell. So therefore your insulin levels are elevated. So night after night, year after year, you get insulin resistant. You see, if you just eat a bad diet, a high glycemic diet during the day, at night when you go to sleep, at least your insulin goes back to the baseline and stays.
Right.
But if you have sleep apnea, now it's elevated at night. And so once that becomes homeostatic, then it moves up a little more. And that's how you develop resistance. Makes perfect sense.
It makes perfect
But people
sense.
don't explain that.
They don't
They should
explain
ask
that.
me.
Well, they should ask you, and they should come see you. And guys, this is why we finally got him on here, because again, you are the bulk of my practice are middle-aged women and older and a little bit older, and men as well. But you know, when you mentioned the hormones, I just almost want to just grab him and hug him, because it's huge. And estrogen is protective of so many things, and and it keeps your arteries and your vessels and all elastic, and it keeps them pliable. It's a part of that. And you know, as you start to lose your hormones, things stiffen and get rigid and all that. And then apparently you also snore more, and sleep apnea goes up more, you know, as we lose our hormones. And so it's so important. And I actually sent a woman to you yesterday. I hope to goodness she calls. I mean, she's I've known her for years, but just, you know, she's getting in through postmenopausal here, and she's snoring more than she's ever snored. And nobody wants to do a sleep study. Yes, you bet.
She's got, you know, if you snore, you got it. I mean, there's a 10% chance you might not, but if you snore, you got it. And the one thing to do to change the whole world is we need providers like you, because you ask yours if they snore.
I do.
But most don't. Snoring is the fifth vital sign. You need to know their blood pressure, you need to know their heart rate, you need to know their temperature, and you need to, I guess you do their respiratory rate. You need to know if they snore. I mean, that's what you need to do. Everyone gets their blood pressure checked. Everyone gets their blood sugar checked. Everyone gets their cholesterol checked. Well, sleep apnea is a higher mortality, and it's more common. Well, and no one's asking if they snore. This is the whole problem. Yet sleep apnea is behind the diabetes, behind the hypertension, and behind the heart disease. And, you know, it used to be real inconvenient. It was a problem. People didn't want to go spend the night in the lab. But now you don't have to. You just wear the thing on your wrist at night. And that doesn't fix every case. There's still about 20% of the patients that end up having to spend the night because we find something else unusual or different. But we can get most people started. In fact, during COVID, we were treating thousands of patients without even having to leave their home. You know,
isn't that
something? And do telemedicine and everything.
Yes.
And that's really what people need to hear. If you snore, you got a problem.
If you snore, you have a problem. So what about today? I had a patient who told me, I said, do you snore? And she said, well, my husband says I snore like twice a week. He has to do this to me over. So is it any snoring or consistent snoring? She said, and she's gained a little bit of weight. This one has too. I mean, yeah. I mean, if you snore a couple of times a night or
if you snore, you need to check it out.
Okay.
If you went and your blood pressure was high in the office, are you going to go, oh, don't worry about it. It's just one measurement.
I know.
Yeah,
right?
You're going to follow up. If their A1C was 6.2,
yeah,
you're going to say, oh, it's just you know, once in a while. No, I mean, if you're snoring, you have an obstructed airway. Here's a test everyone can do. All right.
What is it?
Put your fingers right here on each side of your throat. Feel right here. Now breathe in. When you breathe in, you feel that tightening in your throat. What that is, those are the dilator muscles of your pharynx. See, below the vocal cords, you have trachea that takes the air from the lung. The trachea has these cartilaginous, made of cartilage like bone, rings around it to hold it open. Otherwise, it would collapse, okay, when you inspire. The upper airway, the pharynx, is just muscle, all right, behind your tongue, all right, and then the back of your airway is the muscle over the spinal cord. So, you know, in order for it not to collapse, you got a little trachea there?
I do, because I'm a thyroid person. Okay. So I show them their thyroid.
You can see
that. I didn't know I was going to talk about
I took your thyroid
This is bad news. Now you got to come see me
forever.
For that?
What's the code for? What's the CPT for removing the thyroid?
At least just take half of it off.
So you can see the little rings around here, but once you get up above here, the vocal cords, you're into the pharynx, and it's just muscle. So what you're feeling are those muscles contract to stabilize your airway every time you breathe in, or you would obstruct and you wouldn't pass your air. It would collapse. All right. So when you go to sleep, as everything relaxes, those muscle impulses relax too. Okay. So that stiffening decreases. And that's why people's I'm from the South, aren't I? Yeah. That's why individuals' airways contract or get smaller as they go to sleep. Everyone's airway gets smaller. Everyone.
Now,
for half of the population, that's no big deal. their airway is still large enough for the air to go through in what we call laminar flow, where the molecules don't bump into each other. But for the other half, now their airway is too small. And so those molecules bump into each other, the wall vibrates, and we hear it called snoring. Snoring is a sound. Yeah, let's all do that. There we go. Snoring is the sound of an obstructed airway. It's the sound of someone struggling to breathe. It's, I mean, and so here's the thing. Whether it's partially obstructed and you're snoring, or it's complete obstructed and you have no air movement, the result is the same. For instance, if you started choking me and you were cutting 40% of my air off, or you were cutting 100% of my air off, I'm going to fight back. All right. So when you have this obstruction of the snoring at night, your brain is trying to arouse itself to bring the daytime contraction of those dilator muscles back. So the airway opens back up. So that's what's happening hundreds of times during your sleep. And you have no idea, is you have this transient release of norepinephrine. And of course, we talked earlier, norepinephrine raises blood pressure, raises blood sugar, and your heart does not like it.
No.
And so over time, that's why it leads to hypertension, diabetes. Now, the other thing it's doing, releasing that norepinephrine all through the night, that's fragmenting your sleep.
Yes.
And so it's like someone, popping you in your sleep, every couple of minutes while you're sleeping. Yeah. You're not going to be rested the next day.
No,
you're not going to be your best.
Exhausted.
It's going to lead to memory issues, cognitive problems. It's going to lead to mental illness, lead to more depression and anxiety because you're releasing adrenaline all night in your sleep. You wonder why you're anxious the next day. That's a big issue. So it's huge. It also causes ADD symptoms. So many kids, unfortunately, aren't ever tested for sleep apnea.
Yes.
Or adults, you have ADD. Well, they give you stimulants. Well, because you're sleepy from it too, so it makes you able to concentrate better. But the reason they're having trouble concentrating and focusing is because they have sleep apnea.
Wow.
Now, it's not the whole answer, but it's there.
I wonder if it would increase your risk of like Parkinson's or Alzheimer's disease, because my mom has Alzheimer's. So, and I just wonder if you're obstructing.
So Parkinson's, it would not.
Okay.
It's a different process.
Okay.
But you want to talk about brain damage? It does.
Yes.
So
right.
There's an incredible study from 2015 in Milan, Italy.
Okay.
And they took several hundred patients and that had severe sleep apnea, and they did cognitive function on them. So they did these tests to see how well they could do memory and, simple little formulas and stuff. And then they did MRIs on them. And what they found is almost all of them had white matter degeneration on the MRI. So they put them all on CPAP, or the ones that wore the CPAP, they actually then restudied. They redid their cognitive function. And in 3 months, they'd almost all returned to normal. Okay. But their MRIs hadn't. But at 1 year of CPAP, their MRIs returned to normal. Wow. So not only does it cause brain damage, that, if you intervene and treat them with CPAP, you can actually resolve the process. So now don't think of it as being the process. Like Alzheimer's has a particular mechanism that causes it.
Yes.
Then you have like an alpha-synucleopathy, which is like Lewy body dementia.
Yes.
Well, sleep apnea can cause a similar process, but it's from brain degeneration, so it wouldn't be Alzheimer's. But so many individuals who have cognitive, problems and they snore, well, you can improve mom or dad's function during the day because the sleep apnea is added on top of the Alzheimer's.
Okay.
See what I'm saying?
Yes.
So like depression, it's not going to be the main cause of depression, but it's going to make depression worse.
Yeah, absolutely.
So
absolutely. Wow. That's a great explanation. What about, we've got a lot of questions on here. What about, so here's what I hear. I can't wear that CPAP. I'm not wearing that CPAP.
Yeah.
I can't wear, what's new with CPAP machines? Anything? I mean, does it have to be that great big mask over you? Because that's the main pushback that I get is I don't want to know because I'm not wearing that.
So as we were driving down
let's talk about it.
I actually met the rep from one of the companies that make masks in Nashville to try some new stuff tonight. So Craig and I both, Craig's president of Sleep Centers. So we're both on CPAP. In fact, almost all the guys wear it. Just, it's great. So it's awesome. So I can't wait to put it on tonight. I feel great the next day.
Well, my patients who wear it and it's fit well, and they've actually gone back if they had a trouble and things like that, or gone back if they lost weight, or gone back if they gained. It's like a teddy bear to them. Well, it's like a Snuggie. They tell me this. They won't go without
I haven't gone that far
yet. Well, they do.
Okay.
They don't go without, and they travel the country. I've got a world famous songwriter patient of mine that we sent years ago to you all, and he was young. He was in his 20s, travels the world, right? Back when they could travel the world. And he goes everywhere with that CPAP all over the world. In his 20s, he started. He said, I can't go without it. And he was single, not married. I mean, he's not married. He's got his, and it's not super sexy. I suppose.
Well, I tell you, it's a lot sexier than snoring.
Yeah, it is.
Yeah, or sudden cardiac death in the bed at the end of the day. That's never sexy.
Well, it's a lot sexier than erectile dysfunction because.
Oh, yeah, let's talk about erectile
because
dysfunction.
Sleep apnea is probably the main cause.
Oh my gosh, I'm single, and all the men my age probably all have it.
That CPAP will
that
fix
old
that.
age. Dang.
Okay, it'll fix that, but let's talk about the mask.
Okay, let's get into
I
nothing worse than erectile dysfunction, though, to get a man to wear his
they'll wear it.
It's going to cause
I mean, it could be a gas mask, and they would put it on.
Oh yeah. Okay, let's talk about the mask.
Yeah.
Hang on.
It's so funny.
Let's talk about this. Let's talk about it.
So when I was driving down there, I was in the back seat while we were driving. We had to come down Franklin Road because 65 was just totally blocked.
Okay.
So anyway, I was trying a couple of new ones that have come out.
A couple of masks in the car.
But they're really not masks. Yeah, I was in the back seat and I was showing my wife, hey, is this cute? And she was laughing. So no one really wears a mask anymore.
Okay.
That's we call it an interface because a mask, covers your mouth. Very few patients have their mouth covered. It fits in the nostrils, fits right, seals under your nose like a little cradle under here in the nostrils with a single strap.
Okay.
And that's it. When I have mine on, I can't see it. I can't tell I have it on.
Okay.
All right. And as far as noise, if the machine's making noise, it's not working right. Now sometimes the exhalation as it's coming out, as your exhalation through it, you can hear it. But I mean, put a little fan on in the room.
Okay.
I mean, we get so many patients to wear this. We get very few that don't. And it just takes time. Everyone has trouble. I mean, you just don't sleep for 30 years and all of a sudden you put something on, it's going to be perfect the next night.
That's right.
It takes time to build up to it. The pressure, you sometimes want their mouth to open. When I first put it on, this is hilarious. It was about 6-7 years ago. And actually I'd done a study and it was so mild, I really didn't need treatment. I was just so tired after 20 years, these guys whining about it. So I'm just going to take one home and wear it. So I took it home. I was going to show these guys, this is nothing. So I took the one, fits in the nose and wore it. And, well, I really struggled. I mean, I really did. I didn't do well at all. It was coming off at night. I was having all these trouble. And finally I thought after about a week of it, I said, I don't need to do this. This is stupid. Okay. I don't have it anyway. Why am I doing this? And I thought, all our machines have modems in it, and my office knows whether I'm wearing it or not. And if I quit this, I don't really like the biggest hypocrite in the world.
Yes.
So I just kept putting it back on. In a few more days, I was wearing it all night and I just got through it and I haven't had a problem since. And, so I struggled for 10 days to 2 weeks and I've been wearing it for 6 years. Now, here's what's really funny is after I wore it 3 or 4 weeks, I just said, okay, I proved my point. I'm done. But I now don't have to listen to these guys whine anymore.
Right.
I did it.
Right.
So anyway, I took, didn't wear it for a couple of days and I'm like, I don't feel as good as I did. And I'm like, nah, it's just all, I've been so brainwashed into this. Well, I put it back on. I felt better. Took it off. Didn't feel as good. Wore a couple more nights back and forth. Finally, I'm convinced I felt better, even though mine was mild. So
wow.
I haven't missed 2 nights probably in 6 years.
Really?
I've had it in seven countries.
Travel with it.
Sometimes you have to carry your little electrical thing so you can plug it in.
Yes.
Yes. Converter.
Yeah, your converter. That's exactly right. Wow. Okay.
All right.
So we know that it's a little bit different now, but it does take time to get used to. Very rarely do people put it on and go, whoa, in the first night.
There are those that do. About 1/3 have really hardly any problems at all. Okay. And, they maybe one little phone call and that's it. Another third have a couple problems that because we've treated almost 50,000 patients during my career.
Did you hear that?
Yeah, so,
almost 50,000 patients. He knows what he's doing.
No, I'm learning. So I'm still practicing.
Still practice. That's what I was just curious. That's why we call it a practice.
But I'm telling you, every day I learn something new that helps patients. Every day, a lot of times patients will be the one to tell you, if you just listen to them.
Yeah, absolutely.
Because this is such a personal thing, wearing this. It's not like out of a textbook. In fact, we're writing a new protocol on how to help more people wear it and how to do it all remotely. Like they're getting text every day. We built a texting program.
Huge. That's huge.
You know, we're doing all this coaching where we call them, where they have access to get answers to their questions and little videos to help. And we're building all that. So I've been reviewing all the literature that's out there on wearing CPAP and, you know, just looking at stuff. And there's, you know, we follow everything that's in the literature, but still everyone has their little, you know, particulars. The biggest thing people have to do is just understand, look, you're probably going to struggle for a couple of weeks.
Okay.
And the other thing is you're going to make it. You know, if you're willing to do it, we can get you wearing it. And it's 98% curative. In other words,
so listen to this.
If you wear it, 98% of the patients that will wear it will be fixed totally. There are a couple that, you know, you have to do something else, but that's it. And the problem with it, just get this straight. Everyone says, I want something else other than CPAP. No, you don't. Okay. CPAP's the most effective. It treats 98% of the cases. Surgery gets about 30%. The nerve implant's better for $50,000. But, you know, you have to turn it on with a remote control every night. It shocks you, makes your tongue come forward.
What?
So that's how it keeps your airway open.
Well, I don't want that.
In fact, it has to have a delay on it because you can't fall asleep while it's shocking you. It's just stupid. Or they go get their throat cut on. Or they want a mouthpiece. Well, mouthpiece will work for, you know, a mild case, but it doesn't really work much for moderate, certainly not for severe. And you still have this thing in your mouth all night. You drill it, it can move your teeth, and it can cause TMJ. CPAP can't hurt you. Yes, it's inconvenient at first, but it can't hurt you. All right, so it's totally safe. It's homeopathic. I mean, it's just air from your room at a little higher pressure. It's like you're breathing at the bottom of a mountain and everyone else in the room is breathing at the top. It's just you know, it's
explain what a CPAP is for sure. What you just said, because a lot of people don't even know what's it stand for. CPAP,
continuous positive airway pressure. You're just breathing under a set pressure that we have to determine, or the machine determines what level you need to keep your airway open. Remember, when you go to sleep, airway gets smaller. All right, so this just sort of splints it open, holds it up just enough to where you don't snore. Your bed partner will appreciate that. And the fact that you don't have these respiratory vents. If you don't have the respiratory vent, the obstruction, the snoring, guess what? You're not going to release norepinephrine. Not going to get high blood pressure. You're not going to get diabetes. Is at least less chance of it. And, you know, you're going to decrease your risk of a heart attack by 2/3.
By 2/3.
So
unbelievable.
So this is what you got to think about. This is why CPAP improves blood pressure. All right. Okay. That's why CPAP improves blood sugar control. And that's why it reduces cardiovascular events, improves erectile dysfunction, depression, cognitive function, even gets rid of brain damage. We found from Milan, Italy. So,
isn't that something?
So we don't have any of that. Mouthpieces don't have literature on that. A little bit on blood pressure, a little bit on feeling better during the day. There's no data with the surgery. There's not enough of them. And please don't do that. In fact, your insurance requires you to have to fail CPAP before you would go to surgery. By the way, people don't fail CPAP. They just don't wear it.
Yeah.
Or they won't come back enough and work with us enough to help. Now, sometimes their nose is so bad or some other problem that they have to have their nose fixed in order to wear it, but that's uncommon. Oh. And so the third thing, we said it's the most effective by far. It's the safest, obviously, can't hurt you. It's also least expensive.
And that was one of the next questions. You know, how much does the CPAP machine cost? Teresa asked.
You know, it varies based on your insurance, but you know, with the mask and the machine and everything, it's under $1,000, right around $1,000, between $900 to $1,200, somewhere in there. Okay. Depending on the insurance and, you know, and where you get it. You get it from us, it's always best. And
I agree.
So it's the least expensive. A mouthpiece begins at like $1,500 and they go to $3,000. And of course, surgery starts at, you know, $15,000 to $1,000 and goes to $50,000. It just doesn't make sense. And, you know, people are wanting to get out of it. The other thing about CPAP that's, you know, we talked about, can't hurt you, most effective, the least expensive. It's also the fastest to treatment. We can have you on CPAP in a few days. All right. To get a mouthpiece takes months to have the impressions made and having it manufactured, having it fitted, having it adjusted. And of course, surgery would take months and months to get approved. So, and get you on the schedule. So it's that. The final thing, and I've kind of alluded to this, and that is we have all this research, randomized trials showing CPAP improves all these different things. We don't have that with other treatment. Why would you want it? I mean, it's so easy to just takes a little time to get used to. You know, you start working out, you're going to get sore.
Oh, yeah.
You know, you do something different. It's just what happens. You just kind of have to put on your big girl, if you have female big girl underwear and just go do it. You know, you said you have female patients, so
that's right.
it's not that. Or
Ladies,
get your husband
big
in
girl
here.
panties on, and let's do it now.
You know,
and if I haven't asked you, if I fail to ask you, are you snoring? What's that? Then you need to tell me. Okay, you need to push me and say, hey, you haven't asked me about if I'm snoring or not. So I try to ask everybody, but sometimes it slips through the cracks.
And they think they don't look sexy.
That's what you hear. That's what you hear all the time. Is lay right there with my mask on like Darth Vader. I mean, I hear it. I sit here. Well, they sit right here, and I sit over there, and I listen to it. Yeah.
Well, the mask on, it's just under here now, and the bottom line is, look, when you're doing all night, and slobbering on your pillow, and then you don't feel well the next day, and it makes you more feel as alive and not energetic. That's not very sexy either.
Well, this is what Faye just said. Mm-hmm. Faye says, I put mine on the first night, and for the first time in many years, I didn't wake up with a horrible headache.
Yeah, that's another.
So talk about that.
So because of the oxygen going up and down, you can get bad headaches, and especially in REM sleep, where you wake up out of dreaming REM sleep. The other thing is kind of funny, because sleep apnea tends to be worse in REM sleep because your muscles are more paralyzed.
More paralyzed.
Right. Well, they are paralyzed except for your eyes and your diaphragm. So,
gosh, sounds so great.
Well, but the reason is a lot of people don't dream. So here's some other things to think about if you might have sleep apnea. If you don't have dreams, you don't remember them, you could be having bad, REM related sleep apnea. So therefore, once you get into REM, you pop out into another stage because of the respiratory event, it rouses you out. So you don't ever hold a dream together long enough to remember it. If you sleep on your side, it's more likely to have sleep apnea, because sleep apnea tends to be worse on your back because gravity lets the chin fall back, makes your airway smaller.
Yes.
If you're a mouth breather, you're more likely to have sleep apnea, because when you breathe through your mouth, it makes your airway smaller already because the chin going down collapses it in. So if you sleep on your stomach, you're more likely to have sleep apnea because you're sleeping on your side or your stomach to keep off your back, because that's what happens. And if you drink and you snore worse, well, that means you got it too.
That's what I hear all the time. Oh, I only snore if I drink, Dani. I only snore if I drink. I hear that.
Yeah. But I mean, if your blood pressure is only up when you drink, you still need to follow it and evaluate it. I mean, just remember, we just had the silent killer month. Blood pressure is called the silent killer because, it goes unnoticed for years why it's wreaking havoc on the heart and blood vessels. Mm-hmm. And then you get diagnosed and, all right, you've already got vascular disease or cardiac disease. Mm-hmm. Well, we call it the loud killer. The snoring is loud. It's got a mortality higher than high blood pressure, and it's more common. Mm-hmm. So, but they're not coming to see us. So,
well, we're gonna help change that as well. My next door neighbor, actually, I didn't think about it until you were talking, and I'm not going to be able to find it in the sleep chapter on the book I have coming out. I have a whole chapter on sleep, right?
Good.
Because it's the third step. Well, it's the second step to my 6 steps to healing. But her husband was 26 years old, and she found him dead in the bed from sleep apnea. 26 years old. I'm not quite sure I'm right on that, but he was in his 20s. He wasn't 30. It was devastating. And you know what? He refused to wear his CPAP.
Well, you talk about young.
Yes.
I can talk about this case. I won't mention his name, but it was in the newspaper 10 years ago. One of the MTSU football players, when I did the study with their linemen, he had severe sleep apnea. We found, of course, and we treated him. And he went from not even starting at MTSU to be not only starting the next year, he made all conference and got a tryout to play on Sunday.
Wow.
And he gave the credit to his CPAP machine.
Oh, wow.
One of the reasons was he could stay awake in the meetings too.
Well, absolutely. Right. Yeah. I can't find the other, but yes.
So they're young people can get this.
You bet.
Children get this.
Okay. So that was going to be something. Is anybody born with sleep apnea? Are you born with, I tell women every day, you weren't born with high blood pressure, or you weren't born with, I wasn't born with lupus. I wasn't born with IBS. I turn all of that on. But is sleep apnea something that people could be born with? I wonder.
You may not have it at birth, but yes, you're born genetically. It runs in family.
Okay.
You look like your parents on the outside. You look like them on the inside too.
Wow.
We always think
oh, that's great. I've never heard anybody say that.
You realize that's how genetically you get these features. Oh, you look like your dad. Well, but also the inside structures and other parts, the size, your body type and all that is inherited too. So, if your dad has a short, thick neck, you're going to get that too, or if your mom had it. So if your dad snores or your mom snores, you're likely going to snore. If both of them snore, you're pretty much definitely going to snore. And, that's what happens.
Wow. Keith says, why has sleep apnea diagnosis increased so much? Is there an underlying medical issue?
Well, there's two reasons.
Okay.
Number one is awareness.
Okay.
Okay. That people are becoming more aware. Just, and if we had a pill, there'd be no problem. When the pill comes out for sleep apnea, everyone will know. Big Pharma will make sure. I mean, you won't be able to go anywhere without seeing
yes, they
Danny's little closet over here with samples of drugs. It'll be like you open the door and sleep apnea pills will fall all over you. It'll just cover you. That's it. So awareness is increased. The other thing that's happened is sleep apnea worsens with weight. It does.
Okay.
As you gain weight, your airway gets smaller. All right. So the epidemic of obesity has led to increased prevalence of sleep apnea. Studies done 20 years ago show much less sleep apnea than the one I was quoting earlier, which was from 2019.
Wow. Yeah. Well, Kathy, I don't know about this. She says, I see CPAP alternative machines. Do they work? I don't even know what that is. What is an alternative to a CPAP machine?
There's a bunch of gadgets and gizmos out there that people are trying to, let's be clear, make a buck off, people and the reputation of CPAP, which isn't true. And there's you got 60 million adult Americans out there with sleep apnea. You don't have
60 million.
You don't have to treat except 1% of them with your Gidget, and you made $1 billion. So it's there's all kind of things out there. The treatments are this. If you just snore, there are some things, but you don't know that you don't have sleep apnea until you have a test.
Okay.
So, there are a small percent of the population, about 10%, that snore but don't have sleep apnea. In other words, they have enough obstruction that it's making noise, but they're not alerting the brain. The brain's not reacting. The difference between sleep apnea and just snoring, is that the brain's reacting to it. So you're releasing the norepinephrine, which leads to the sleep fragmentation, the fatigue, the high blood pressure, the diabetes. It's the brain's reaction. But remember, 90% of you are going to have the brain reacting to it enough that it's going to be a problem. All right. And the more frequent the brain reacts to it, the more severe the sleep apnea. So it's not how severe your obstruction is or how severe your snoring is. It's how frequent your brain's reacting to it, and you don't know because you're asleep. And your bed partner won't know either. I mean, if you don't have a partner, like Lori's saying over, I have no idea if I snore anymore. She's lost 115 pounds. Well, that's amazing.
Lori has.
That's amazing.
Lori, I am so proud of you. You have no idea. And she did it on her own. On her own. She worked real hard before I came along, and she's taken it a little bit further now. But so, and she doesn't know if she snores.
Impressive. I'm just trying to lose the COVID-19 I put on.
The COVID-19. That's exactly right. Listen to this. My 18-year-old daughter has severe apnea, stopping over 900 times a night when she had her sleep study. What? She just got her CPAP machine. Well, Tamitha, good. Well, make sure she wears it. That's a lot of stopping.
Yeah. That's suggesting that her apnea-hypopnea index was 100. And that's very frequent. But we have them as high as 120, 130 at times. Anyone over 30 is considered severe. What? So you can see that's 3 times what severe is. Now, she's not stopping 100 times an hour. And this is what sleep doctors have done to really sort of mess us over. And I used to be guilty of this 25 years ago, is that when you're trying to explain to patients that they have this obstruction that is triggering their brain to release norepinephrine, whether it's a partial obstruction, snoring, or a complete obstruction.
Right.
All right. It's too complicated to them. So they go, you stop breathing 30 times an hour, or in this girl's case, 100 times an hour. Well, they don't stop breathing. No one stopped breathing with sleep apnea. You're obstructed. You have to, I mean, with another type of sleep apnea is rare, called central sleep apnea, you actually stop breathing. It's a good term. But see, the word apnea is misleading. And that's why we use the word sleep airflow obstruction, because the word apnea was coined by Professor Guilleminault back in 1975 at Stanford. The first sleep studies only measured apneas, complete stoppage of breathing, not partial. So we didn't realize till the 80s that the partial obstructions, snoring, were just as dangerous. They had the same sequelae if they trigger the norepinephrine release. They cause the same pathophysiology, the same disease. All right. So they never changed the name. So many people think, oh, you have to stop breathing in your sleep.
Oh, yeah.
You have to pause in your sleep, either breathing or hold your breath in your sleep.
Yes.
That is not true. If you snore, you're obstructed. You need to be evaluated. Okay, that's it. It's just we never changed the name. That's why we're going to sleep airflow obstruction away from sleep apnea, because the word apnea is misleading. Let me just make this clear. Many people with sleep apnea don't actually have apnea. They just snore, but they're having release of norepinephrine, the fight or flight reaction to the obstruction. Again, if I'm choking you, blocking off 40% of your air or 100% of your air in apnea, okay, you're going to fight back. And it's the fighting back, that fight or flight reaction, what causes all the problems.
This is fantastic.
Good.
Thank you. You've really explained it. And everyone's talking about that too, about just how informative this is and how you've broken it down. Now, this was a question, Denise, I was going to ask, and because I do have a fair amount of patients who come here who don't have insurance or at all. Mm-hmm. So there's a cash, I realize it's different for probably free, but without insurance, where do you go for this? Testing alone started at $1,000. How much are the machines? So when people are a cash pay, I know our labs are less expensive and things like that. How's that work?
I'll be careful here, because the business people that run this, may disagree, but I would say that a cash patient could get tested, undergo a complete consult, thorough, not just looking for sleep apnea, but all sleep disorders, go through the process, get started on CPAP for $1,200, $1,500 at most. Okay, that's
don't
everything.
Hold him to that though.
Well, I'm saying maybe $1,000. It depends. We're physician referred.
Yes.
Okay.
And that was my next question. I was actually going to ask you, Is it referral only? Like somebody?
No, they can come.
Okay. That's what I wanted to make sure, because,
we don't market to the public.
Okay.
So, we're here servicing, the great providers in Middle Tennessee like Dani, and we're here for that. But if someone calls our office, yes, they'll be seen, and they'll get great care. They'll get the same care. And we see a lot of patients with cash, and I wish I knew those numbers. That's not my department.
Right. Sure.
But I would think that the test would be the watch pack. You'd wear it overnight, and, we'd have the result the next day, uploads to the cloud, and you do a consult. And if you need CPAP, but the key is the consult. That's, we're not trying to take patients from Dani and other providers. We want to intervene with our expertise at that we call the crucial moment, to take the data from the study, take your history, physical, everything else, put it together. Here's what you have. Here's the best treatment for you. It may be a mouthpiece. Okay. I guarantee you it won't be surgery right off the bat.
Right.
But there are other options. If you're really mild and you just snore and you don't have these respiratory events leading to the sleep norepinephrine, there's even a new sort of a TENS unit for the tongue that you actually wear this 20 minutes a day for 6 weeks, and it actually
shocks your tongue.
Well, no, it sort of trains the muscle in it to help it stay out of the airway, and it can be effective in very, very mild cases.
Really? That's what Jody was just asking. Can you have sleep apnea even if you rarely snore? Rarely snore.
Okay, so this is really important. Not everyone with sleep apnea snores. About 90% do, kind of the same as what percent of snorers have sleep apnea. Some people, if you had any kind of surgery in your airway, it can be scarred down, or if you had even from tonsils when you're younger. So if it's scarred, then it doesn't vibrate. So when you have the obstruction, you don't hear the noise.
Okay.
So in other words, it's the obstruction is the issue. Usually the snoring's telling you there's obstruction. Okay. But you can have obstruction without noise.
Okay.
Is that?
Wow. Okay. Well, I'm doing my sleep study tonight. So,
I'll call you tomorrow.
Oh gosh, Lord, I got to do it. I've already said I'm going to do it.
What time do you get up in the morning?
4:50 a.m.
Well,
unless call me tomorrow morning.
Well, sometimes I get up that early because I can't get something off my mind and start writing and go down to my computer.
Oh yeah,
but I probably won't call you that early.
Okay, 4:50.
But I'll call you. I'll call you when I get there.
I want you to call me tomorrow. So, okay, Jody says from my experience, I don't snore, so I don't know. So, Okay. Anything else that we need to talk about? Because I know that this has been action packed. And God, ladies and gentlemen, I am so thrilled that you guys took time tonight on a Wednesday night instead of a Sunday to do this, because this was so important. Anything else that we need to share? They know how to get in touch with you. I've got it going up here, right there, and the phone number's going. Anything else we need to say that you would really think is important?
Guys, help your family and your friends. The loud killer is running rampant in America because no one's really recognizing it. People don't understand how easy CPAP is. They don't understand how inexpensive and easy it is to get tested. And, we're really hurting our future. The thing about sleep apnea, the reason genetically it doesn't go away, or I should say, in a population, because you get it and you die from it way past your reproductive years.
Yes.
So it continues to go through families. If you have families that they all had heart attacks in their 50s, you look at them, all those guys, they all had sleep apnea. That's what does it. So you think about your blood pressure. You worry about your cholesterol. Yes, Big Pharma's pushing all that, but you need to address your snoring. That's key.
Wow. Don't ignore it. Don't just move to the other room either, like a lot of people do. They just move out of the room with their partner.
And elevating the head of your bed like these beds. Oh, we'll fix your snoring. Yeah, you spend $5,000 for a bed worth $500, and yeah, that's really not going to help.
No. Somebody did ask on here on the mouth guards. It was recommended they get a mouth guard. Do the dentists make them? Who makes the mouth guard? Where do you get them? Or do you all do mouth guards as well?
Well, we have dentists who just do that. Oh. Okay, so you don't. I have dentists all the time calling me, hey, I want to make mouthpieces for you. Well, we've got several that they're boarded in it. Oh. And that's what they do all day. They've been doing it for years. And the mouthpieces, they're tough to fit. I mean, it takes a lot of experience, or it can move your teeth or cause TMJ or, rub something on your, on your gum. You don't want someone making their first for you.
Oh, no, never. No, never. Or part-time. Like, you don't want a part-time heart surgeon working on you. He goes and lays hardwood during 4 days a week and does heart surgery 2 days a week. That is hard work. But I mean, you want a full-time person doing whatever it is they're doing. Trust me, that's a big one, people.
Well, but making mouthpieces is important thing.
Well, that's what she said. Her dentist had no idea really and had no idea how to do it. So she went.
Well, come see us. And that's one of the things going on. A lot of dentists are out there practicing medicine because they can make money at the mouthpieces. So they're wanting to do testing and all that. And I get it happens all the time where, they make a mouthpiece. They've adjusted it 3 times. They can't get the patient fixed. So finally they send them to us and put them on CPAP and they're great. But the mouthpiece was never going to work. Remember, it's great for mild. It can work for moderate. But you can't do a mouthpiece from a home study. Home studies underestimate the amount of sleep apnea. Home study is not the same as an in-lab.
Right.
It's a great
and
test.
I was wanting you to say that because I always push the inpatient in-lab visit with people. I just thought it was, but I'm going to do this tonight and see because I don't think I snore, period. So,
that's one of the things we can help too. If you need an in-lab, we're about 1/4 or 1/5 the cost of a hospital-owned lab. It's a reasonable price and it's under $1,000 and it's Medicare is half that. So it's a great situation. Home study, think of it like the COVID rapid test. The rapid test for COVID, if you have symptoms of COVID and you do a rapid test and it's positive, you got COVID.
You bet.
Same with the home test for sleep apnea. But if the rapid test for COVID is negative and you have symptoms, you have to assume you still have COVID.
Yes.
Right.
Yes.
Well, see, if you have risk factors for sleep apnea and your home test is what we call inconclusive, it can't be negative or normal because it underestimates and it has night-to-night variability. It's a fantastic test. It's convenient, it's inexpensive, it's quick, but it's not the same as the gold standard in lab.
Right.
But we now diagnose 75 to 80% of our patients with a home test.
Wow. And they just keep getting better and better also. I can't wait to try this today. And it looks very easy and it's not going to stress me out tonight.
It's really simple. Just on your wrist and a little probe on your finger. Put it on a smaller finger. Your fingers are fine size. Yeah, guys, if they have big fat fingers, it can get tight because it's going to compress. It'll inflate to 30 centimeters, so it blocks out the venous tone and it's picking up the arterial tone.
Okay.
And so what it's doing on this test she's wearing tonight in the finger, it's picking up the norepinephrine release, So when your airway's obstructed, the fight or flight reaction happens. And so you'll have an increase in heart rate and an increase in artery tone, from the norepinephrine, and you may have a little DSAT with it that will pick up, and that's how we tell the event. On an in-lab,
oxygen levels going down. He's talking about.
On an in-lab, we pick up that norepinephrine release by your change in brain waves.
Ah, okay. All right. Well, I can't wait to do it. Dr. Noah, I appreciate you so much.
Bill.
We had Bill. We had so many questions, and the girls are going to be answering your questions tonight or tomorrow on here as well if you have questions, because there were a whole lot of questions that came up here, and I appreciate you so much. Thank you. And if anything new comes out, we're going to have you back on here.
Oh, great.
Again?
I am taller than you. I know it doesn't look that way.
Oh, he's a real tall guy. I think you just slid down.
I think I'm just such a big guy. I sink down on the couch. And you're up here on your knees. Yes, the COVID-19.
We got all this going on, and that's what he thinks about is I really am taller than you. He is. He's a great big tall guy. All right, guys, I appreciate you so much. You are so welcome. This Sunday night service is Dr. Terry Walsh. Guys, it's been years me trying to get her on here, and she reached out to me to be on our Sunday night service. And if you don't know Dr. Terry Walsh, she wrote the bestseller, The Walsh Protocol. 100% healed herself from multiple sclerosis. She's a medical doctor at Cleveland. Well, she was in the VA and at Cleveland Clinic for years. She was in a recumbent chair for years, could not walk. 100% since 2010, I think, has not been on one medication, and she healed herself by healing her gut. So she started with a paleo diet, and she's healed herself with food, and food that creates mitochondria in your body, and that helped her make ATP and energy and all the things. Sunday night, 6 p.m. right here, Dani Williamson Wellness. You guys have got to get on here and show her some love, because she's the real deal, and it's a big deal getting her on here. So almost as big a deal as it is having Dr. Bill here. But all right, we appreciate you. Thank you. Have a good night.
Night, guys.
Bye, guys. Go get your sleep study.